Professor Anuradha Madam is an eminent and a senior woman nephrologist from Hyderabad, and she was the first woman nephrologist to start nephrology program in Osmania General Hospital, to her credit. And she has a lot of areas of interest in the field of pregnancy and renal failure, and she is the chair for Indian Society of Nephrology and Southern Chapter Nephrology, and a lot of national and international publications to her credit. I request her to present on the topic of cardiorenal syndrome, ma'am. Thank you.
Thank you for that introduction. Good afternoon, everybody. First of all, let me wish all the women in this audience a very happy International Women's Day. I'm going to talk today on a topic which has become quite common now, especially for the cardiologists and nephrologists, and which is called the cardiorenal syndrome. So we all know that for a long time that cardiac and renal diseases commonly coexist, which increases the mortality, morbidity, and the cost of care. However, there has been no consensus definition or classification of this interrelationship between the kidney and the heart. And with the result, there has been a limited appreciation of the epidemiology, the standardized diagnostic criteria, and prevention and treatment has therefore been fragmented and single organ centered. While the main function of the kidney is to regulate the volume and blood pressure, it also maintains the electrolyte and acid-base balance, and it has some hormonal functions. The main function of the heart is to regulate the perfusion pressure and to see a good flow to the periphery, apart from the hormonal function that it has. To have a better understanding of the interrelationship between the heart and the kidney, a consensus conference was organized under the aegis of the Acute Dialysis Quality Initiative, bringing together world leaders in nephrology, critical care, cardiology, cardiothoracic surgery, and epidemiology in Venice in the year 2008 from 3rd to 6th of September. And I'm very proud to tell you all that one of my students has been a part of this consensus conference, which was held at Venice. And to discuss the definition, the classification, the epidemiology, the diagnostic criteria, biomarkers, prevention and protection strategies, and the management of cardiorenal syndrome. Under the umbrella word cardiorenal syndrome is a disorder of the heart or the kidney, whereby the dysfunction of one organ may induce acute or chronic dysfunction of the other organ. So a very simple definition, but in cardiorenal syndrome there are two important aspects. The first one is the sequence of the organ involvement. So it is the sequence of the organ involvement, whether it is the heart first or the kidney first. If the heart is involved first, it is called cardiorenal. If the kidney is involved, it's called renocardiac. And the second most important aspect is the bidirectionality of the signaling, leading to a vicious circle. So whatever the organ primarily involved, due to various physiological derangements and changes, the other organ also gets involved. The cardiorenal syndrome is classified into 5 major types. The first is the acute cardiorenal syndrome, which is an abrupt worsening of cardiac function leading to AKI. The classic example of this is the hemodynamically mediated AKI secondary to acute heart failure. Second is the chronic cardiorenal syndrome, chronic abnormalities of cardiac function, which lead usually to CKD. And third is the acute renocardiac, where there is an abrupt worsening of kidney function leading to an acute cardiac dysfunction. The fourth is a chronic renocardiac, which is CKD or a chronic kidney disease leading to chronic cardiac dysfunction. And the fifth is a secondary cardiorenal syndrome, where there is a simultaneous involvement of both the heart and the kidney. Coming to the pathogenesis of the cardiorenal syndrome, let's look at type 1. We know that the organ first involved is the heart, and through various pathogenic mechanisms, one of the most important is a hemodynamic mediated damage. Because of the cardiac illness, there is a decreased perfusion to the to the kidney, there is a decreased cardiac output, there is a venous congestion. So all these lead to hemodynamic mediated damage. The second most important pathogenetic mechanism is a humorally mediated damage, which leads to increased amount of vasoactive hormones like norepinephrine, angiotensin II, and endothelins. Some of the exogenous factors like drugs like ACE inhibitors, diuretics, or contrast-induced drugs can cause AKI. And of course, whenever there is a disorder of the heart, there are some immune-mediated damage. There is upregulation of some cytokines like TNF-alpha and of course some hormonal factors like BNP. So all these can cause secondary involvement of the kidney. The five subtypes of acute cardiorenal syndrome are: one is, we know the most important is the acute decompensated congestive cardiac failure, pulmonary edema, hypertensive heart failure with a preserved left ventricular ejection fraction, isolated right heart failure, and cardiogenic shock. And the underlying causes could be anything between from an acute coronary syndrome, valvular heart disease, hypertension, arrhythmias, and non-compliance with heart failure therapy. Coming to cardiorenal, the same pathophysiological mechanisms operate also in cardiorenal syndrome type 2, where because of the chronic nature or a sustained pathophysiological mechanisms leads to a chronic kidney disease and ultimately leading to sclerosis or fibrosis of the kidney. The major causes of heart failure, we all know, are coronary artery disease, again the same, hypertension, valvular hearts, cardiomyopathies, some toxins, some endocrine disorders like diabetes and pheochromocytoma, nutritional thiamine deficiency, circulatory failure that we most commonly see as in sepsis, and some other systemic diseases like amyloid. Acute renocardiac, which is type 3, is primarily the kidney is involved, and we know the kidney is the major organ for taking care of the fluid and electrolyte balance. Whenever the kidney fails, we have a volume expansion that leads to heart failure. There is a severe drop in GFR. There is a sympathetic stimulation, RAS activation, intense renal vasoconstriction, electrolyte and acid-base disorders, and some humoral signaling. All these lead to a secondary heart failure. There are various definitions used to diagnose acute kidney injury. I've just put one here, but we have, this is a slightly old presentation. So we have, nowadays we have various other criteria for acute kidney injury. This is the rifle classification. We have the Akin classification, which is the acute kidney injury network classification. We have the recent classification by the KDIGO. So all these are to diagnose acute kidney injury especially in an ICU setting. The pathogenesis of acute kidney injury causing heart problems are whenever there is a decreased GFR, it leads to salt and water retention. The cardiac changes are due to paracrine changes. There is almost always a renocardiac crosstalk going on. Metabolic acidosis and dyselectrolemia add to the problem. Coming to chronic renocardiac, this is what most of us see. A chronic kidney disease patient has a 10 to 20 times more incidence of a cardiac abnormality and cardiac death, and these are related to a lot of factors like anemia, uremic toxins, calcium phosphate abnormalities, nutritional factors, salt and fluid overload, and a chronic inflammatory state. So these are some of the problems in patients with chronic kidney disease which impact the heart. And staging of chronic kidney disease, I'm not going to go into the detail because we just know that the KDOQI has classified into 5 stages based on GFR, or also on not only on GFR but also on some markers of kidney damage, either by the imaging techniques or by histology. And last, we have, of course, pathogenesis. We know it's due to salt and water. Again, the same thing I've already told you. In addition to what I've told you, some other factors are in a patient who is on dialysis, a patient having an AV fistula, there could be a high output failure. Pericardial effusion can cause tamponade, and arrhythmias because of, especially due to potassium abnormalities. Secondary cardiorenal syndrome, class 5, is due to simultaneous involvement of heart and the kidney. One of the most important clinical scenarios that we see in the ICU is sepsis. And sepsis involves both the heart and the kidney. There are a lot of causes, but what is common with us that we see is systemic sepsis. So we know that knowing epidemiology, cardiorenal syndrome has been described for better management of patients with both cardiac and renal diseases. And therefore, it seems prudent that we understand the epidemiology of the different types of cardiorenal syndrome, which will aid us not only to treat the patients, but also to have to foresee the problem and to evolve strategies to prevent the occurrence of a cardiorenal syndrome. These are all mostly retrospective studies, but however, because there have been no prospective studies to know the exact epidemiology of cardiorenal syndrome, type 1 cardiorenal syndrome occurs in around 19 to 45%. That is, about 19 to 45 patients of acute decompensated cardiac failure have AKI. Type 2, about 45 to 60. Majority of patients of chronic heart failure have CKD. Type 3, there is a lot of heterogeneity because of the different definitions used to describe acute kidney injury. So there is no definite epidemiological data on type 3, which is an acute renocardiac. Type 4, we all know that patients of chronic kidney disease have almost a 20-fold increase in cardiac mortality. And type 5 again is largely disease and context specific. So when we look at the heart failure and a worsening kidney function, we know it's just a web. One leads on to the other and perpetuate both the diseases. I'm not going to deal with in detail about the biomarkers. As of now, we know that biomarkers is an area where there is an explosive literature and research going on, and all this is to find out the earliest markers, because we know that any organ failure, the damage starts at a cellular level before it becomes clinically evident. And if we can identify the patients at that stage by using some biomarkers, we can maybe evolve strategies to prevent the disease occurring. So, but what is important when we are talking of biomarkers is, can biomarkers help identify and classify a cardiorenal syndrome? Can they identify patients at risk and predict reversibility? Can they be useful as targets for therapy? What is the role in monitoring effects of treatment? And can we combine them effectively to aid in the diagnosis and management? We all know that as of now, we do not have many renal biomarkers, although there is some data on NGAL, which I'll come to later, but we know that we have some biomarkers as far as cardiac disease is concerned. The most important of them is the troponins, the natriuretic peptides, but we have not, beyond that, we don't have many other biomarkers in the offing. What are the future biomarkers? Especially in the area of kidney, we have a host of biomarkers like NGAL, which is a 20 kilodalton protein, which rises anywhere within 2 to 6 hours of acute renal failure occurring, because for the serum creat, as of now, we depend on serum creat, which takes at least 24 to 48 hours to rise, whereas NGAL takes about within 2 to 6 hours, both in the serum and in the urine, you can measure it. And NGAL measurement could be one of the earliest biomarkers for identifying acute kidney injury. But then the major question is identifying and showing that there is an increase in NGAL. Is it really going to affect the management? As against cardiac, where you will plan some interventions, in as far as the kidney is concerned, all we can do is optimize their fluid balance, avoid nephrotoxic drugs. But beyond that, whether these biomarkers are really helpful in preventing or aborting the cardiorenal syndrome is questionable. So as of now, we have BNP and pro-BNP. They have prognostic utility. Cardiac troponins denote an ischemic myocardial injury, and some other pro-inflammatory cytokines that can be used. And the ideal biomarker should be able to identify the primary location, should be able to differentiate AKI from CKD, should discern the AKI subtype, identify the etiology, stratify the risk, estimate the prognosis, define the course, and allow monitoring of response to intervention. But unfortunately, where the kidney is concerned, I don't think we have any biomarker as of now which fulfill these criteria. So clinically important biomarkers, I already told you, there is, we have now NGAL, it is being done. If Chakravarti is here, yes, I think it's being done in Care Hospital, but we need to get data from him regarding the usefulness of NGAL in management of patients with AKI. Cystatin C is another biomarker which rises days before rise in create. KIM1, which is a kidney injury molecule, is highly specific for AKI, especially hemodynamically mediated AKI. N-acetyl beta-D glucosaminidase, NAG, is increased in all the conditions, and some others like IL-18 which increase. So we have biomarkers, but the utility of those in a renal setting has not been established. So imaging, we have, as of now, we have echo, we have stress echo. In the kidney, we have just perfusion scans, we have functional, maybe a renal morphology in patients who on whom we can do a biopsy. Future imaging can be like MRI imagings may be the future in both kidney and in the heart. I'll just dwell on one slide regarding the prevention of CRS. It just covers everything because prevention is identify the cause. So the key concept in type 1 will be to prevent decompensation of a stable heart failure. In type 2, which it will be optimal medical and device treatment of heart failure. Type 3 will be prevent AKI. Type 4 will be attenuate the progression of CKD. And type 5 is to treat the underlying systemic illness to minimize end organ injury. So we have a lot of drugs which we will come to in the management, but we know one of the cornerstones of management of heart failure is ACE inhibitors, ARBs, aldosterone antagonists. Well, they were very promising. There was especially when it came into the market, but I think it has gone a little behind the scene now. And of course, there's always a place for ECF volume control, diet, and diuretics. Of course, type 3, we know whenever there's an acute kidney injury, we have to take care of hydration. We have to be very careful when using nephrotoxic drugs, especially the contrast drugs, and avoid hypotension. And type 4, we manage CKD as per the KDIGO guidelines. Type 5, we have to optimize both cardiac and renal function and identify the systemic illness and treat it accordingly. Coming to management, my last few slides. The various drugs used in cardiorenal syndrome, well, I just want to emphasize the fact that in type 2, especially in a chronic heart failure, beta blockers and ACE inhibitors and ARBs and aldosterone antagonists are life-saving. They are not of much use in type 1. In type 3, they should not be used. In type 4, they are renoprotective. Diuretics have some role in type 1. They are again in the absence of definite ultrafiltration devices here, the diuretics seem to remain one of the mainstay management of type 2 CRS. Type 3, when there is an established AKI, the role of diuretics is minimal. And of course, in type 4, in patients who have some output, it is used to control hypertension and fluids. Management of acute heart failure, I think in an audience which mostly consists of cardiologists, I don't think I am the appropriate person to talk about management of acute heart failure, but then we look at patients who have a very low systolic blood pressure, and in them possibly we consider a preload reduction, judicious use of fluids, inotropes. And if the systolic blood pressure is a little higher, we can use vasodilators, nitrates, and some newer drugs like nesiritide and levosimendan. If there is poor response to all these, you would have to look for a mechanical support. Current treatments, just 3-4 more. Current treatment of acute decompensated heart failure, we rely on diuretics, ultrafiltration, vasodilators, which decrease the preload and afterload, inotropes, which increase the contractility, and the role of natal natriuretic hormones in decreasing both preload, afterload, and neurohormones. Disadvantages of conventional diuretic therapy is that it has a potential to activate the neurohumoral responses. It can cause a lot of electrolyte disturbances. It has been associated with increased risk of morbidity, can lead to the development of prerenal azotemia, and may result in diuretic resistance. I think I'll skip these slides on diuretic resistance, but I'll just talk about ultrafiltration is a method where we use a transmembrane pressure which is generated by the device, and this allows for the formation of ultrafiltrate via a convective transport. And what are the advantages of ultrafiltration over loop diuretics? Ultrafiltrate is isotonic with plasma, whereas diuresis of loop diuretics is virtually always hypertonic to plasma. Ultrafiltration removes more sodium than diuretics. It does not cause any electrolyte disturbances. It decreases the ECF volume more than a comparable volume of diuretic-induced fluid loss. So ultrafiltration definitely provides an additional modality for fluid removal. It allows for a predictable amount to be removed. It rapidly removes salt and water and is safer than diuretics. And this is one machine which I have no personal experience with that, neither have I seen a demo of this machine, but this is called the Aquadex. It's an advanced form of ultrafiltration. It can be done as outpatient and inpatient, peripheral or central venous access, and it's a highly automated. As I told you, I do not have any personal experience. Management of chronic heart failure, we have already talked about the role of AC inhibitors and ARBs. Management of so CKD management, AKI management, I think we all know the standard of care. Take care of hydration, avoid electrolyte disturbances, take care of nutrition, dialyze as and when necessary. So these are the key aspects of management of AKI. Management of CKD, we have to take care of anemia, we have to take care of bone disease, we have to take care of electrolyte disturbances, and of course azotemia. So in conclusion, kidney and cardiac disease frequently coexist and impact each other. 5 subtypes of CRS share some similarities in pathophysiology. They have important discriminating features in terms of predisposing factors, risk identification, natural history, and outcome. And there's a clear need for prospective studies to characterize the epidemiology across various subtypes. Thanks for your hearing.